you doing today? Nice to see you.
Fine, nice to see you.
Thank you very much for your time. I appreciate it. This is my first time coming in, and I'll start off with a pedra. And if I get a chance, I'll go into Lantus with you. Doctor, can I ask you just a quick question with regards to your insulin treatment? Do you use multiple daily injections for your patients with regards to mealtime insulin?
Multiple injections, you mean before meals, short acting?
Yes.
Yeah, we use it.
Okay,
when we
good.
need them.
What type of insulin do you typically use?
Amylog, Novolog,
Yeah.
this one.
Do you just whatever's on formulary, or any perceived advantage of one or the other?
No, whatever's in formulary.
Yeah, I know that's typically what it is. Are you familiar with Apidra by any means?
I heard about it.
Heard about it. If I could take a moment just to discuss, uncover some of the benefits and unique clinical advantages that Apidra offers over other rapid actings on the market. Maybe that might help you change your prescribing habits slightly to try Apidra on some patients where you see it as a benefit.
Yeah.
Would that be of interest to you? Apidra basically is indicated for type 1 and type 2 patients, and obviously your type 2 patients, 90% of them are obese and overweight, and the concern around that is it usually takes typically more insulin to get through the subcutaneous layer of adiposity tissue, the fat, and a lot of insulins lose their rapidity. They don't have the ability to get through the absorption tissue without losing its rapidity. So the benefit of Apidra, because it has a smaller amino acid chain, it actually has more monomers versus hexamers and dimers, so it's just a smaller amino acid. It has the ability to get through and really offer your postprandial coverage a lot quicker when compared to Lispro and regular human insulin. We basically looked at a glucose infusion rate, and we looked at non-diabetic patients. Why we looked at non-diabetic patients? Because they really don't have any factors such as insulin resistance that would really alter the response that we're really trying to acquire. And typically in your type 2 diabetics, they have a delayed response at that first phase response, and type 1s obviously don't have any. But you can see, as represented by the line in blue, Apidra has a slightly faster onset of action, a higher peak of action, whereas compared to Lispro is slightly similar as far as action, but you can see how the difference here, you're going to get more coverage for your glucose with Apidra. And you can see that it's out of the system relatively as fast as Lispro. So is that typically why you're using a rapid acting? Is probably because of the physiologic aspect?
Yeah, fast.
Yeah, it's fast, exactly. And I think that's where the confidence interval, when you compare Lispro and glulisine and regular insulin, it has a statistical difference right here. So I think that may be an advantage when you start talking about the clinical data. But I mentioned to you about absorption. Fast is fine, but if you can't get into the bloodstream when needed, it's really not going to help your patients as they need it. So we basically looked at patients with BMIs from 25 to 35 or greater, and we noticed that at every single endpoint from 25 to 35, we maintained our rapidity when compared against Lispro. And again, we looked at patients with patients that were non-diabetic patients, so we're trying to get that true response. And you can see, as represented by blue and Lispro and orange, the difference. What do you think about that? Do you think that that could be an advantage for your patients, that they can get mealtime coverage a lot faster?
Definitely, yeah.
I think so too. I think that really, it may not be a huge clinical advantage, but none of the rapid actings on the market will really show any major advantages statistically. And at least by having a minimal advantage over the course of a lifetime of your diabetic patient, that will really truly make a difference and really help them reduce those complications in the long run. So this is our BMI data with regards to absorption. Efficacy, obviously with the agents on the market, I used to sell Lispro for several years, and I never knew that there was no statistical reduction in A1C versus regular human insulin in their clinical studies. It was kind of a surprise to me. But more importantly, we use these rapid actings because they have the ability to offer less hypoglycemic events and get more physiologic control. So, but we actually showed a statistical difference, and this information was actually provided from a physician out of the Scripps Clinic in California, Dr. Daly. And there's only one key point that I'd like to share with you with regards to this data. Dr. Daly stated that the greater the baseline endpoint reduction in HbA1c observed with glulisine was statistically significant. Although the clinical relevance of this difference remains to be established, such a difference has not been established previously in rapid-acting analogs. Again, that's not a huge difference, but this is in type 2 diabetic patients, and this is the largest clinical study ever done as far as multiple daily injections go. So over the course of a lifetime, that may offer a benefit for your patients, because that's truly the only way that you can measure your success as far as A1Cs go. Obviously, if your patient's feeling better, that is great, but sometimes what you're feeling and what's going on in your body doesn't always correlate. Type 1 patients, do you see a lot of type 1 patients? Or you send them off to an endocrinologist?
Yeah, they start their life with endocrinologist.
Yeah, exactly. We are equipotent versus Lispro, and if you had to choose between Lispro and Novo or whatever, just so you know that they're, as far as type 1s, we do have similar efficacy, and that's as far as I'll state with that. One other key point to mention with regards to dosing with Apidra, you typically probably dose your patients 15 minutes before, I imagine, as an indication recommends.
Yeah.
But in some instances, do you think your patients may not adhere to that, and they may miss a meal or dose a little bit later?
Happens in real life, yeah.
It does, and with Apidra, it has the opportunity to dose up to 20 minutes after a meal. And so whether you dose it 15 minutes before, you can, but you could also dose it 20 minutes after a meal, maintaining you have efficacy pre and post meal. So that's critical to know, because if you could take it afterwards, you want to know that it's safe and efficacious, and at least you know that there's data to support it both ways. Whereas with the other agents, you will not see that clinical benefit for them. You can't take Lispro immediately after a meal, but after that, there's no data to support it. So at least with Apidra, you can rest assured that you're going to get that safety as far as efficacious results go. So with regards to Apidra, I've talked to you about the flexibility, I've talked to you about how it can get into the bloodstream much faster, and I also talked about the timing of dose, where it can really help your patients live a more normal lifestyle. Do you have any questions that would withhold you back from using Apidra on a daily basis?
No, actually, no, I mean,
Good.
it sounds good.
It is good.
You should switch to it, yeah.
Well, excellent. If you are going to switch patients over, it's a unit-for-unit dose switching, and I'd love to hear about some successes that you do get with your patients. And obviously, multiple daily injections is the toughest to really accomplish intensive control. But we know you, KPDS and DCO and DCCT, really support intensive treatment to avoid micro and macrovascular complications. I'll leave you the study with Dr. Daly, a type 2 study. And I'd also like to just ask you a little bit about Lantus. And I know that I think you mentioned that you are familiar with Lantus. You do use it on a regular basis. And are there any particular patients that you wouldn't use Lantus on?
No.
No. So you just go to Lantus every time. That is great.
Well, I don't know what contraindications, is there any?
Contraindications, hypersensitivity to any known excipients of Lantus, and then hyperglycemia is one of the obvious issues with any insulin on the market. But there's some latest data that you may or may not have seen, and I'll just, if you give me a second, I'll just support what you're currently doing. Now, when I used to sell the premixes, and the ADA recommends only use it in special circumstances, but some physicians will use it because obviously not every patient is going to adhere to any exact regimen. But this is from last year at the ADA, and Dr. Hammer actually presented this, and this is just a really quick bit of information. He looked at patients that had diabetes for 8.6 years, and they had an average A1C of 8.3, which is actually the A1C of the typical diabetic patient in the U.S. population. So a lot of physicians will say, Sean, my patients are the goal. Well, you may have a majority of your patients, but in the overall scheme of it in the U.S., average patient has an 8.5 to 8.7 as far as uncontrolled. So that's really representative of the true population. Basically, premix plus orals and premix alone, we switched them to Lantus plus orals. And this is kind of unique because this 8.3, they were able to decrease the A1C down to 7.2 in as little as 3 months. So with that type of control, I think more importantly, it's due to the titration factor, where you can get excellent titration and get your patients to go quicker, whereas with other insulins, you don't have that flexibility. And do you think that's kind of significant and supports why you use Lantus? And do you currently use that Lantus pen on a consistent basis as your first choice when starting someone on Lantus?
Now, yeah, that's what I'm doing.
Okay, excellent. Well, I've taught you about Apidra, the basal, or the bolus, and I've taught you about Lantus as the basal. I think that an excellent opportunity is a basal bolus combination. And as far as I'm concerned, if you need anything, anytime where I can help you and assist you in your practice, I'd be more than happy to help you. Patient education, clinical information, if you just let me know, I can find the right resources to help you with your practice on a daily basis.
Okay.
Will you, in opportunities where mix may arise, and patients that may come over from another practice, and they are on a mix, just keep in mind that you are seeing excellent efficacy with regards to that, and I know that you have clinical experience to support that. So, So thank you very much. I appreciate your time today, and I look forward to seeing you in the future.
Very good. Thank
Thank
you.
you.
Mm.